Hi everyone, welcome back to Journal Club. We took a little hiatus for the past week and now we're back. And I am going to be here with Dr. Ramika Dhar, who I'm just waiting for her to join us. Um, and it looks like, oh, she's very quick. Great. I'm going to just bring her on camera. Just adding right now. Hi there.
Hi.
How's it going?
Good. Thank you for
Good.
having.
Yeah, no, welcome. Hi, Kate. Okay, so tonight I was just saying we are, so Dr. Dhar is a geriatric psychiatrist, which is awesome. So because tonight's Journal Club article is covering a case of a 72-year-old. So I just wanted to read you guys her bio before we get started. Dr. Ramika Dhar is a geriatric psychiatrist working as an assistant professor in the Department of Medicine at the West Virginia University School of Medicine in Morgantown, West Virginia. She completed her residency at the University of Arkansas for Medical Sciences in Little Rock, followed by a geriatric psychiatry fellowship at the University of Pennsylvania in Philadelphia. She works as a dementia specialist in an internal medicine clinic, providing consultations in long-term care facilities, and she sees inpatient geriatric psychiatry consults in the hospital. She's also involved in didactic teaching and supervision of internal medicine and family medicine residents. She has been a member of Psychiatry Network for the last 4 years, and she enjoys learning from other colleagues and sharing our journey during these challenging times. So thank you again for agreeing to do this, and you can go ahead and take it away.
Sure. Thank you. Thank you, Christina.
Sure.
So today's topic of presentation is actually different because it's not a journal article. This is going to be a case discussion, which is from the case records of Mass General Hospital, published in NEJM in 2017. So basically the case is presented by Dr. Robbins, who is a psychiatrist, and then on the panel you have other specialists, a neurologist, a pathologist, and a radiologist. So the case is...
And what's the... Oh, go ahead. I was just going to ask, what's the case titled?
Yes. So the case is, sorry, the case is titled A 76-year-old Man with Fever, Weight Loss, and Weakness. So I'm gonna talk about the case, the history, the exam findings, and then we will have a differential diagnosis discussion, just like we used to have on teaching rounds. This is not like a psychiatric case, it's purely neurological, so hopefully it will refresh our memories. So this 76-year-old male lives in New England. He presented with to the hospital with a 3-week onset of weight loss, generalized weakness, and fever. Before presenting to the hospital a couple of weeks earlier, he had gone to his primary care physician where he had complained of dyspnea on exertion, diffuse myalgias, and fatigue impacting his ADLs. His vital signs were stable then, and multiple labs were obtained by the primary care physician: vitamin D, B12, comprehensive metabolic panel, ESR, serology for HIV, Hep C, syphilis, which were all unremarkable. And the only finding was occult blood was positive on stool examination, and a colonoscopy was scheduled. 3 days prior to admission, the gentleman continued to have fever with non-bilious, non-bloody vomiting and had an unwitnessed fall. He was brought to the ED where he denied any headaches, photophobia, or neck stiffness, which are basically meningeal signs. And then his past medical history is significant for hypertension, diet-controlled diabetes mellitus, and vitamin D deficiency. And the only medications he's on is lisinopril and aspirin. So he's a healthy 76-year-old pre-morbidly compared to the general population. Family history is negative for cancer and autoimmune disease. He's a former smoker, 20-pack year history, but quit 30 years ago. Occasional alcohol use, no illicit drug use. He's retired, lives in New England, does not have any history of travel outside this region in several years. No pets, no exposure to bats. He recently cleaned his basement where he occasionally saw mice. On exam, he's running a temperature. His vital signs, blood pressure, pulse were normal. His oxygen saturation was 94%. He was alert and oriented times 3, and the initial neurological exam was unremarkable. There were no rash on his skin. With these complaints, of course, in the ED, a pan CT scan was done, which was top to bottom, heads, chest, abdominal, pelvis, and there were no acute findings. So within 12 hours of admission, he deteriorated further, developed altered mental status, confusion, difficulty with word finding, and difficulty following commands. Lumbar puncture initially was attempted but was unsuccessful. And so he was empirically, I believe, being treated for meningitis, which would cover everything, bacterial and viral. So it was IV vancomycin, ceftriaxone, ampicillin, and acyclovir. Then an MRI was obtained with and without contrast, and there were some on FLAIR, some signal abnormalities were seen in the supratentorial white matter. There was no acute infarct or hemorrhage or any masses. EEG showed intermittent irregular delta slowing in the left frontocentral area and then diffuse theta slowing in the background, but there were no epileptiform events. Now, he had been in the hospital for 48 hours, and then finally lumbar puncture was done successfully. His opening pressure was 19.5. You can refer to table 1, where it gives you the findings from his blood work initially, and then his CSF analysis. So basically, CSF analysis, we would like to know about the color, turbidity, the red cell count, total white blood cells, neutrophils, glucose, and protein. And in his case, we can see that he had a high white blood cell count, along with more towards neutrophils and then lymphocytes. The glucose levels were actually normal, and the protein levels were elevated. And I'll come back to the CSF findings in the discussion. He continued to deteriorate, became tachypnic, went into respiratory failure, had to be intubated, and is on mechanically ventilated. So on 4th hospital day, again, an MRI was done, which showed new mild diffuse hyperintensities in the sulci. So in figure 1, you can see that in figure panel A, you see the arrows. The arrows are basically showing the hyperintensity in the medial temporal lobes and the thalami, which is panel B and C with the arrowheads. And then in D, you see scattered hyperintense foci in the white matter, most prominently in the left corona radiata. So anybody who's great at neuroimaging might understand it better than I did. But on exam, he had complete total flaccid paralysis. So basically all lower motor neuron signs, no deep tendon reflexes. Pupils were mildly reactive. There was no withdrawal to nail bed pressures. And then nerve conduction studies and EMG was done. Nerve conduction studies showed decreased amplitude in the left medial and ulnar nerves. EMG electromyography showed fibrillations in the muscles, which I think is susceptible of myopathy, and then rapid change, and that's it. So basically, we have this gentleman who was in previously good state of health, who just had a really rapidly declining neurological course. So in this case, now you have all the experts who are now going to doing the differential diagnosis with evidence for and against. So looking at this, if we are suspecting a CNS process, we can look at CNS vasculitis or venous sinus thrombosis. but usually they don't present with fever, and the CSF analysis is usually unremarkable, whereas here you have some markers of infection. And also the MRI symptoms, MRI signs are not suggestive. Looking at cancer, CNS lymphoma or a glioma, of course, you will see typical MRI findings. However, would not explain the findings in CSF. Also, there is no evidence of metastasis, which tend to appear on MRI as, ring enhancing lesions. Then looking at toxic and metabolic causes of encephalopathy, or also known as delirium. Carbon monoxide poisoning, in which the classic signs on MRI are diffusion restrictions in the basal ganglion. Or you could have thiamine deficiency. His history was inconsistent, and also the CSF findings are not consistent with that. Now, everybody's globally looking at encephalitis, which is inflammation of the brain tissue. So in table 2, you have the diagnostic criteria for encephalitis. You have a major criteria, which is to be fulfilled, which is altered mental status lasting 24 hours or more with no alternative cause identified. And then you have minor criteria. And just like Alzheimer's, you basically divide it into possible and probable based on the number of minor criteria, which is documented temperature, either generalized or partial seizures, new onset of focal neurological findings, which was present in this case, increased white cell counts present in this case, new or acute abnormality of brain parenchyma, which we have seen on the MRI on day 4, and then abnormalities on the EEG. So when we come to encephalitis, again, we are dividing it into non-infectious and infectious etiologies. And in non-infectious, you will look at autoimmune. Either out of the autoimmune conditions, neurosarcoidosis was one of the possibility. However, it does not have such an acutely fulminant course. It's more insidious. Or you have acute disseminated encephalomyelitis, also known as the acronym ADEM. Now, this is more common in children. Either it can be due to post-vaccination or actually post-viral infections, measles, mumps, and rubella. And usually it presents with upper motor neuron signs, and you see demyelinating lesions on MRI in the white matter. The other possibilities, limbic encephalitis, the CSF findings would not be the way they are in this gentleman. Coming to infectious etiologies, which could be either bacterial, viral, fungal, rickettsial. Amongst bacterial infections, you can have Mycobacterium tuberculosis in children, although it's not applicable, but in children we see E. coli, H. influenzae, or you can have syphilis, and people who work with farm animals. You can have the Borrelia infection, babesiosis. Then you have the viral infections. So initially, when I was reading the case, I only was thinking of herpes simplex encephalitis, which is actually the most prevalent cause of encephalitis worldwide, HSV type 1. Some pointers about HSV is that I think it's frequently was tested in USMLEs, was on EEG findings. You have PLEDS, the periodic lateralized epileptiform discharges, PLEDS, PLEDS. You have typical frontotemporal signs because there is orbitofrontal cortex involvement, and you can present with personality changes, focal seizures, and even like a Kluver-Bucy syndrome because of the temporal lobe involvement. I was talking about the CSF analysis. So as a rule of thumb, typically, the CSF blood glucose levels, the normal CSF blood glucose level is 2/3 of our serum blood glucose levels, as a rule of thumb. Usually in bacterial infections, the glucose levels are actually low, and this is attributable to the bacteria, like having reduced glucose transporter receptors, and I mean, the mechanisms are not exactly known. Protein levels are elevated in both viral and bacterial infections. However, in viral infections, the glucose levels are usually normal. Then also, if you see red blood cells, you either have to first rule out a traumatic TAP, which can also artificially elevate the the protein levels, or you are looking at subarachnoid hemorrhage. And also the color would be yellowish when you look at it. So now, so based on these findings, the panel is now discussing, so what could it be? The CSF findings are more leaning towards a viral etiology. It doesn't seem to be the HSV type 1, so what could it be? So here's when the geographical and the seasonal history comes into play. So whether where the person is located, is there any travel history or history of immigration, what is the immune status, exposure to animals, what's the occupation. So in this case, in New England, the arboviruses are the most prevalent type of viral infections, which are vector-borne, either through mosquitoes or tick. The West Nile virus is actually the most common cause of infections in New England. I wasn't aware of that. However, only 10% of patients who are infected with West Nile will have, say, symptomatic like flu-like illness. And out of those 10%, only 10% have severe neurological complications. So this gentleman was the unluckiest of them all. And also, despite the fact he didn't have any severe immunodeficiency, except for like diabetes, which was diet controlled. So unfortunately, with the West Nile virus, unlike HSV, we don't have a treatment and a antiviral treatment. So basically, it's supportive. In this case, IV immunoglobulins were tried. However, the patient continued to decline neurologically and functionally. Had a G-tube tracheostomy and just had a very downhill course from there, and ultimately died on hospice. One thing about West Nile is that the polymerase chain reaction, which is the most rapid, although it's an expensive test, but it's the most rapid assessment test we have, and it has helped us in detecting HSV earlier. However, the PCR is usually negative in West Nile, and the reason given is that the viral replication occurs for a short duration only. And so the PCR assay would be negative by the time patient presents. The IgM antibody levels will become elevated within 11 or 12 days. So you basically do an ELISA, the enzyme-linked immunosorbent assay. People who have neurological complications with West Nile will have a 50% mortality rate. So that's the case.
Okay, thanks. That was really interesting. No, seriously, I was like riveted. I feel, well, these are like little mysteries. I didn't read the case ahead of time, so I was really like waiting for the final answer. I don't know if anybody has any questions. Feel free to ask. Let me pull that up. Hi, Kip. You're asking which article? This is the article. This is the case of the 76-year-old with fever, weight loss, and weakness. For anybody who is just joining us, we did just wrap it up. So you can watch this video anytime after it ends. It doesn't have to be live for you to get the CME credit through American Physician Institute. The directions are at the top of the post. Dr. Dhar, I don't see any questions right now, but sometimes people ask them like over the next 24 hours or so.
Sure.
So we'll try to get back to anyone who has a question.
I think it was purely neurology focused. As I said, I really had to like refresh and read back about a lot of things. As I said, except for HSV, I really wasn't sure of West Nile, and so I kind of learned something.
I thought I was like back in my infectious disease class.
Yes, exactly. And I mean,
but I do think that we we could get consulted when the patient becomes
Yes,
delirious. I feel like
sure.
psychiatry would be consulted, especially if they haven't found a cause yet, for help. And then hopefully, like, we don't brush it off and continue to push for additional
Yeah,
testing,
yeah,
which I think is hard to do sometimes. So I'm glad that they went that far and figured out what it was.
yeah, yeah. And
Yeah.
unfortunately, it was a tragic course. Um, yeah, next
Yeah.
week I'm presenting on delirium, which is my favorite topic. So,
Oh, it is? Oh, great. I only know like one other person, one other psychiatrist who loves delirium that much. So,
yeah,
no, so that'll be good.
yeah,
All
and,
right. Well, thank you.
yeah. And if anyone
Yeah.
has questions, please feel free to let Christina know or me, and I'll try to look it up.
Okay.
So, thank you.
And yeah, we'll see everybody this Wednesday. We have another journal article. The full schedule, you can find it at Psychiatry Network, etc. And yeah, we'll see you in a couple days. All right. Have a
Thanks,
good night,
thanks,
everybody.
Christina. Good
Thank you,
night.
Dr. Dar.
Bye.
Okay. Thanks. Bye.